Okay, so welcome everyone to this session, looking at values and preferences for contraceptive methods that we have used to inform the WHO global guidelines on contraception. My name is James Kiarie. I'm the head of the Contraception and Fertility Care Unit in WHO, and I'll be moderating this session. And to provide you a bit of background to what the session is about, we know that really to get universal access to contraception, it's really a fundamental thing for us to have access to all the methods for you to realize the right to family planning, and placing values and preferences at the center of our thinking is very critical for us to ensure choice. To achieve choice and autonomy, we really need to consider the values and preferences of the people that we serve. And as a global normative body, WHO works a lot with its partners to produce evidence-based guidelines. And for this session, we'll be really looking at two guidelines that WHO produces. One is the medical eligibility criteria, that is also referred to as the MEC, and this deals with how the safety of contraception for women, for the methods, for women with different conditions and characteristics. So it looks at safety depending on characteristics and conditions of users. The other guideline is the selected practice recommendations, which deals with how the providers can safely provide contraception. It deals with about initiation, continuation, and use of contraception. So these two guidelines are the ones which have really been informed by the values and preferences reviews that we'll be discussing. And today we do have very excellent partners that we have worked with from USAID and also from Johns Hopkins that will be presenting. I would like to just highlight from as WHO, we always think about conflict of interest. So just to say, none of the presenters today have declared any conflict of interest. And this is important. When you hear from people, you know that they are presenting the knowledge just as it is. So for the agenda today, we have several reviews that we'll be listening to. The first one will be looking at a global systematic review, looking at values and preferences. And the next, we'll look at contraceptive values and preferences of pregnant women, postpartum women, and women seeking emergency contraceptive services and those seeking abortion services. And then next, we'll hear on contraceptive values and preferences of adolescents and youth. And lastly, we'll hear about a review on contraceptive values and preferences of health workers, and also looking at women living with HIV, sex workers, transmasculine individuals, and people who inject drugs, and also those who are living in humanitarian contexts. So it is quite a broad area that we are going to cover, but we do have excellent panel of speakers. And what I'm going to do is that I'll introduce each speaker before they present, because probably if I introduce them now, by the time they come around to presenting, you'll be starting to wonder who they are. And but before we have the session, there was a poll. It's always good to get a sense of the room. So, yeah, Anita will take us through the poll.
So if everyone wants to pull their phones out and go to slido.com, or there should be a QR code, 1 second. And then just enter the code 5560739. Everyone got it? So we just wanted to start off with what comes to mind when you think of contraceptive values and preferences. Feel free to just put in anything, everything, a couple of words, a phrase. Should start populating. That's a pretty big one. These are some really great answers. I think we're probably going to be touching on pretty much everything in this word cloud. Yeah, choice is definitely, I think, exactly the center of a lot of, family planning concepts. So, all right, well, maybe we can pause it for now. There will be some other polls during the session. So, going back to James.
Thank you so much, Anita. So unfortunately, our first presenter could not join us physically, but she has recorded her presentation, so that's the one we'll listen to. And Marilyn Garfield is a scientist in the Contraception and Fertility Care Unit in WHO. And in this role, she leads WHO guideline portfolio on contraceptive safety and effective service delivery practices. And her research interests include contraceptive safety in women with medical conditions, implementation of strategies to optimize access to family planning among postpartum women, and methodologies for developing evidence-based guidelines. So welcome to the presentation by Marilyn Garfield.
Good morning, everyone, and thank you for joining this session. I'm very sorry not to join you in person along with my colleagues, but for the next few minutes, I'm going to give an overview of the work that a team of us did over several years to produce 6 systematic reviews addressing contraceptive values and preferences for contraceptive users, as well as the values and preferences of healthcare workers. As probably you all well know, and have heard much talked about during this year's ICFP, WHO has been produced for more than 30 years. Primarily, the medical eligibility for contraceptive use guideline and the selective practice recommendations for contraceptive use guidelines. Those are the preeminent guidelines that WHO produces to address safety and effectiveness of contraception. We also have our app to facilitate decision support among frontline providers. And we also has, many of you may have heard, yesterday we launched an updated version of the Family Planning Handbook. This photo here is from 2018, 2019, so I hope that all of you soon will have the 22 version. We also work closely with colleagues to ensure that self-care is included in our work. Now, since WHO began to develop requirements for guideline development, one key factor was to insist that the grade approach to guideline development was followed. And the role of values and preferences. Additionally, we believe that by developing recommendations that consider values and preferences, we are further supporting users, men, women, girls, and boys, to identify and then use effectively the method of their choice. And we hope that by further understanding values and preferences of users, healthcare workers can be equipped to better counsel and better tailor their counsel clients.
Maybe let's look into
So,
that
for the
sound. Is there a problem with the way it is playing? It wasn't playing like that before.
No, it's like this.
Yeah?
It's from the
Should I download like the other version we have? And then play that? Okay, well, if everyone doesn't mind looking at my email for a second, we have another version of Mary Lynn's. Don't think it's. Hmm?
good morning from afar.
Okay, yeah. So,
Good morning from afar. Perhaps as a start, we began with the evidence-based guidelines the WHO has been producing for nearly 30 years, namely the Medical Eligibility Criteria for Contraceptive Use Guideline and the Selected Practice Recommendations for Contraceptive Use Guideline. These two guidelines, along with the Family Planning Handbook, really give the support that program managers, policymakers, and practitioners need to provide quality services for clients everywhere in the world. We also have now an app, and we also have, our department has developed guidance for self-care, and I'm sure you've heard much about that during this year's conference. Also, I'd like to just put a little pitch that yesterday WHO, along with USAID and Johns Hopkins University and many partners, issued a new edition of the Family Planning Handbook. So the slide here, the cover I show, is outdated, but all of these guidelines and tools rely on robust, published clinical and epidemiological evidence to inform them. However, we now recognize that the role of values and preferences of end users is equally as important and needs to be considered when developing any guidance. WHO strongly believes that by viewing and assessing values and taking values and preferences and considering them, this goes a long way towards supporting users in their efforts to identify and use the contraceptive methods that they've selected. And also, by taking consideration of values and preferences, we further equip frontline health workers to better understand the needs of their clients and perhaps better tailor their counseling. Since WHO embraced the GRADE process to produce evidence-based guidelines, considerations of values and preferences has been considered an essential factor within the process. And what we mean by this at WHO is values and preferences are, in effect, the relative importance of people, or in our case, family planning clients, assigned to outcomes associated with an intervention or exposure. So outcomes related to using or not using a family planning method. For the purposes of the reviews that we'll be discussing today, we applied Gordon Guyot's GRADE definition of values and preferences are the collection of goals, expectations, predispositions, and beliefs that individuals have for certain decisions and their personal outcomes. Additionally, our group considered how people feel about methods and how they prefer to make choices as also a part of values and preferences. Now, to undertake this effort, we took some time. We searched 10 electronic databases. We also searched prominent literature reviews. We searched these reviews, their reference lists, to identify if there were any articles that did not appear in the bibliographics database searches. We wanted to make sure that perhaps we would look in reference lists to make sure that we didn't miss anything. We applied a span of from January 1st, 2005 until the end of July 2020 as the range of dates where we would search literature. We used this specific range because we wanted, while we did want to be able to cast a wide net, so to speak, of what people place value on, we didn't want to look at values and preferences among contraceptive users, for example, who were using methods in the 1960s, because now there are more methods and also methods have changed over time. So we wanted to keep the search more as current as we could without compromising the search. We didn't place any language restrictions, nor did we place any setting restrictions on country, geography, or location of where people were receiving their contraceptive methods. We also, and importantly, for the purposes of the WHO guidelines that we showed earlier, we were really searching for medical conditions or personal characteristics that are part of the MEC guidance. We also wanted to look out for particular situations that are addressed in the SPR. So we're really trying to make this as relevant as we could to what people values and preferences could pertain to the MEC and SPR guidelines. We did not exclude qualitative studies. So we included quantitative as well as qualitative studies from peer-reviewed articles. So we did not search the gray literature. And we assessed the study rigor of qualitative studies using the critical appraisal skills program, and we applied an 8-item evidence project scale to assess the quality of quantitative studies. So these scales, we're looking at for example, for quantitative studies that lost to follow-up, rigor of the study design, appropriate of the study questions. We were looking also in the qualitative study as we were looking at the population, the appropriate methods, reporting, recruitment, as some of the criteria. Now this slide shows you, with this search, we still found a lot of citations. So the bibliographic search alone identified nearly 15,400 citations. We also found quite a number of citations when we look through prominent literature reviews. When we removed the duplicates, though, however, we cut the number of citations in half, literally, and then when we started to apply our inclusion-exclusion criteria to the citations that we found, we whittled the list down to 423 articles that fit our global review inclusion criteria.
Now, of these 423 articles that we found, we're pleased to say that all of the WHO's 6 regions were represented. The articles drew upon populations in country in all of WHO's regions. Populations were drawn from 93 countries. Additionally, countries were each of the 4 World Bank classifications for income level were included in these studies. Overall, of all the studies that are included in the review, we had over 463,000 participants. So we found not only a large volume of studies, but also a large population to be drawn upon. 250 of the citations came from high-income countries. 44 of the articles came from low-income countries. Nearly 2/3 of the studies included were quantitative, and 8% used mixed methods. And the most commonly discussed methods in the 423 articles were IUDs, copper and levonorgestrel IUDs. Now, this, when we did our search, we were really looking for trying to find as broad population groups as we could, and also that would correspond to the needs of WHO's guidelines. So in this slide here, you can see that most of these studies really included results on female contraceptive users. Fewer studies reported on values and preference for male users, and a little over 10% included both men and women. We did find a few studies speaking to what nulliparous women, pregnant women, and postpartum women feel. We also found a good number of studies among young people and among people living with HIV. Additionally, we found quite a few studies that looked at what healthcare workers felt, what are their values and preferences about contraceptive family planning methods. Going further into the populations that we found and the conditions in the global review, we found that we weren't able to find studies that spoke to all of the more than 80 conditions in the MEC. We weren't surprised by that, but still this definitely speaks to the need for additional research. But we did find quite a number of studies speaking to issues around bleeding, of associated with implants, IUDs. We also found quite a few studies around emergency contraception, initiating of IUDs, and also studies speaking to what women living with HIV think and feel about contraceptive methods. And then we found a few, one or two studies for specific method conditions in the WHO MEC, and rheumatoid arthritis is in the CDC's, the US MEC. Now, you may wonder, we talk about the series of systematic reviews that were published in July 2022, and just to say that from these populations, of the 6 reviews, 5 of them really focused on young, and you'll hear more about this, particular populations, clients in specific social situations or practice. We did, and so we didn't find all of the MEC or SPR recommendations as something addressed to that, but we did find quite a few studies, and you'll hear more about this later. Now, what did these studies say? So globally, overall, there were several very prominent themes that emerged from this diverse body of literature. Primarily, as no surprise probably to many of you, more than 50% of the studies reported that values and preferences of users focused, a lot of their opinions focused on the theme of the extent or lack of side effects and the safety of a method or concerns or about that. Also, a number, nearly 50% of studies, the values and preferences, the theme around how effective a method, how reliable the method was. Well, is my patch going to fall off? That kind of thing. And then also closely followed behind, women are very keen to have methods that are easy to use, that are user controlled, and they do. Some studies reported preferences toward long duration, others towards being able to control and return to fertility, coming back quickly. Of note, cost and affordability was a topic that was recorded mostly from studies coming from the United States. Going a little more detail into the most common themes across the global review, as we were noting, side effects emerged as the main theme from regarding values and preferences. And indeed, of the studies we found, side effects was a very common theme among populations from Africa, PAHO, and European regions, the Americas, Europe, and Africa. And when going into greater detail, the side effects were reported as the pain, clients wanting methods where there were few bleeding changes or disruptions in menstrual cycle, limited effect on libido, improvements in acne, and whether or not there were hormones in the method. With regards to reliability and effectiveness, the effectiveness to prevent pregnancy, and also the sense of security. We have some quotes in the reviews about women really feeling relieved that they don't have to worry about becoming pregnant. That was something that emerged in quite a few studies. And additionally, how easy was it to use the method? How easy was it to obtain the method and maintain and switch the method? So, and also quite a few studies in the ease to use catchment spoke to users wanting to have control of when they could stop a method and how quickly fertility would resume. Interestingly, cost again was not reported in globally, but heavily, primarily it was coming from the United States. When talking about methods preferences, we found over in the global review that preferences of methods varied widely, and it was dependent upon what methods actually were available to the clients. So and also method preferences were really dependent upon what the user felt about whether they were willing to use a hormonal method or they really want to use a non-hormonal method. But we did also find several studies where if a user felt confident and with their choice and had been able to get the method of their choice, there was great satisfaction reported. So in conclusion, very broadly, based on this literature, contraceptive users desire methods that have few side effects, are easy to use, and highly effective. They do appreciate having a range to choose from. They appreciate having the information and being able to gain advice from a health worker, but in the end, they want the decision to be theirs. We must remind you that there are indeed limitations to the methodology we used. For one, we used a very broad methodology. We did not perform meta-analysis. We also may have missed articles from the search that we did. And the quality and rigor of the studies that we did include the review varied widely. Population size varied widely, and the extent of reporting. So we are, in a sense, somewhat limited by what the studies did report. However, and we did, there was a tremendous variety in what the studies reported within and across studies. So although there are some limitations, there are quite a few things that we can take from this. For one, we believe that by taking notice of the importance of values and preferences in decisions, we can actually improve our programs. And we can improve the way we counsel and the tools that we prepare to support provision and counseling. We note that context and the available methods is something that very much is going to shape what people think about contraception. And we promise that we will take these findings to inform the future revision of the MEC and the SPR guidelines. So just as a little reminder, I believe this is shown in a lot of places, but you can look at this link here to gain more information on the systematic reviews in this series. Thank you very much.
Yeah, thank you so much to Marilyn for that presentation. As you realize, it was important to have that, and apologies for all the challenges with learning to go hybrid from virtual. Our next presenter, Anita Dam, is a technical advisor in the research division of USAID's Office of HIV/AIDS. She's working on introduction and access of HIV prevention technologies. But before joining the Office of HIV/AIDS, she was a senior program analyst in the Office of Population and Reproductive Health, hence her role in these reviews. And her work focuses globally in the area of sexual and reproductive health and HIV integration, particularly working on designing and managing implementation and behavioral science research and conducting mixed methods evaluations and development of guidelines and policy. Welcome, Anita.
Thanks so much, James, and thank you everyone for coming out to our panel today. Just want to start with a quick disclaimer that the research I'll be presenting today does not necessarily reflect the views of USAID or the United States government. But anyway, as Mary Lynn mentioned, we have conducted multiple systematic reviews to inform the update of the WHO contraceptive guidelines. So I'll be delving into the findings from one of these systematic reviews. And I would like to thank my co-authors, Teresa, Caitlin Kennedy, and Ann Burke, who is not with us today. And you'll be hearing from Teresa and Caitlin shortly as well. So I think we can all agree that values and preferences around contraceptive methods are dynamic over the course of a woman's lifespan. And these changes may be related to significant reproductive health events like planned and unplanned pregnancies, or may follow a woman's changing relationship status or health status. And of course, related to the availability of contraceptives and evolving societal norms and structures. So the study I'm going to be talking about today, we really just delved into the values and preferences for women with specific reproductive experiences. So in particular, we looked at pregnant women, postpartum women, women seeking emergency contraceptives, and women seeking abortion services. So as Mary Lynn mentioned, from the global review search, we ended up with 423 articles. So out of those 423 articles, for this review, we included 23. And within these 23 articles that met the inclusion criteria, it was representative of 10 countries. You can see them on the map there. They included the US, Kenya, Nigeria, Ghana, Italy, Malawi, New Zealand, Senegal, South Africa, and the UK. 16 of the studies only presented quantitative data, 5 presented qualitative, and 2 presented mixed methods. And then within the subgroups I mentioned, 4 articles had results on pregnant women, 12 on postpartum women, 3 on women seeking emergency contraceptive, and 4 on women seeking abortion services. So from the data that was abstracted from the 23 articles, we found varying contraceptive values and preferences among the 4 subgroups. The main themes across the subgroups were influenced by method effectiveness, access, availability, convenience, cost, side effects, previous experience, partner approval, and societal norms. I don't think necessarily anything I'm saying right now is very surprising to anyone in this room, but doing these searches again and finding these results, it's at least very reassuring that we know that these values and preferences are influenced by these factors and continue to be. So while we organized our findings by the different subgroups, we also noted similarities and differences across these groups. So for example, the values and preferences of pregnant and postpartum women were very similar, as both concerned the women's preferred contraception after delivery. And like these 2 groups, women seeking abortion also undergo contraceptive counseling in a health facility. And therefore, all 3 of these groups may have more readily available access to methods, like, for example, the convenience of immediate, LARC insertion following an abortion or a delivery. So then, in contrast, women seeking emergency contraceptives may not have this guaranteed scheduled time to go through contraceptive counseling like these other 3 groups. And then multiple studies across subgroups showed that users' preferences changed over time, and often due to previous experiences, fertility plans, and other health considerations. So 3 common themes emerged from our findings, when comparing these subgroups, and they can be generalized into benefits of contraception, side effects, and the values and preferences of LARCs. The specifics of these 3 themes varied by population group, showing threads of similarities in many cases, but ultimately differed based on each user's health and personal situation. So I can't tell you that, all postpartum women prefer IUD, or all women seeking, abortion services seek fertility awareness methods or anything like that. We did not find those patterns in our results. So I'm just going to start by talking about benefits. We found that women satisfied with their family size, we found satisfaction with family size was seen to influence contraceptive preferences. So women satisfied with their respective family size tended to prefer long-acting or permanent methods, while women desiring children in the future generally considered contraceptive use within the timeline of their planned future fertility, and tended to then prefer short or barrier methods. Other benefits of each contraceptive method centered around access, availability, and convenience for the user. So, for example, women using emergency contraception cited the convenience of the method, not only for accessibility, but also for the use without their partner's knowledge. And then in contrast, no contraceptive method had all the features users deemed important. But then within, the features they did deem important, there was, users had to basically weigh the pros and cons of a method and using it based on effectiveness, side effect profile, and user control over a method starting and stopping. And then like Mary Lynn mentioned, side effects was such a huge area for all the systematic reviews, including this one. So not surprising, side effects was a key theme in most of the included studies. Side effects were usually cited among the top 3 reasons to use or not use contraception among these 4 subgroups. And users tended to discontinue a method, switch, or lose confidence in using contraception as a whole because of side effects. In multiple studies, women described choosing a method because it had fewer side effects than another method, but no method was ever perceived as having 0 side effects. And I think that's, a key theme that all of us are pretty familiar with. Side effects most mentioned within these studies were disruption of the menstrual cycle, mood-related, sexual side effects, and physical side effects. And then the last big bucket of results from this review had to do with values and preferences of LARCs. So many studies emphasized long-acting reversible contraception, including the convenience of accessing LARCs and concerns about side effect profiles. And many of the studies discussed this dichotomy between appreciating the convenience of immediate LARC placement and having concerns about the method like side effects. This emphasis reflects the global trend of increased uptake of LARCs in the past decade, and this increased user accessibility and uptake of LARCs was part of a greater global commitment to ensure broad access to a wider choice of methods, with donors and manufacturers ensuring lower commodity costs and higher availability. So this was, on one hand, a really great finding, but on the other hand, also served as a limitation for our review. Because while it's very important to capture users' values and preferences because of the years that we included in our search, there was a skew toward more studies that reported on LARCs, contraceptive values and preferences, and therefore limited the ability to assess, values and preferences for the entire contraceptive modern method mix. So in conclusion, a key finding for this review is that individuals' contraceptive values and preferences are not static, but often change over time. As method availability changes and LARCs may become more commonly used, values and preferences may continue to change. Individuals must have access to a full range of safe and effective modern contraceptive options, allowing people to make decisions based on evolving contraceptive preferences over time. And lastly, future contraceptive guideline development, policy, and programmatic implementation should continue considering the added influence of these specific reproductive experiences and life events on contraceptive values and preferences of users to improve access, counseling, and method choice. Thank you, and I'm going to now turn it over to Teresa. We're going to skip the polls.
Thank you, Anita. And Teresa here is our next presenter. She's a research associate at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health, Social and Behavioral Interventions Program. She applies qualitative and quantitative methods to developing, describing, and evaluating strategies to improve health and well-being of people living in resource-limited settings. Welcome, Teresa.
Thanks. Okay, Anita's much taller than I am. Okay. Hello, everyone. Thanks for being with us today. I'm happy to share about one of the other reviews in this series focusing on adolescents and young adults. And I'm glad here at this conference that we do have such a focus on young people. So, like all of the other reviews in this series, we took that global review and then popped out the set of articles that focused specifically on adolescents and young adults. Why do we care and focus on this special population? Well, adolescence and young adulthood globally is a really important time in terms of health outcomes. We have a nice confluence of both high rates of unintended pregnancy and this high unmet need of contraception during this very special period of growing up as a young person, having lots of psychological changes, lots of social changes, going through various educational phases, and developing physically as well. And so working through all of these different transitions sets the stage for long-term health outcomes. And so we wanted to focus on this very special population. For this review, we paid attention to young people from ages 10 all the way to 25. We were open to any contraceptive methods that were included in the MEC and SPR. And to do our analysis, we used descriptive content analysis on the articles that we found. And so of the 423 articles in the global review, we pulled out 55 that focused on some disaggregation of young people, and that included over 9,000 young people in 16 countries around the world. Most of these focused on young women, and some included both young men and young women, and only one of these studies focused only on young men. Most of these, again, took place in high-income countries, though there were representations among the other income classes by the World Bank, and many of these studies came from qualitative work. I'm presenting here a quick table, just as a FYI. There were 18 content areas that we pulled out as we examined the various values and preferences of young people and adolescents, and I'm going to talk through a few of them that stood out. So first, we found out of these articles, 24 of them talked generally about general contraceptive preferences, and these ranged from side effects, like Anita just talked about, ranging from weight gain to changes in mood to having acne and physical appearance and changes in your menstrual cycles. Some people desired more regular menstrual cycles. Other people desired to not have them at all. And these different side effects could be viewed with either positive valence or negatively or pretty neutral, just saying these are the side effects that we are experiencing and they are what they are. Another general preference that was noted across contraceptive methods was just concerns about hormones and what does that mean for me as a person and what am I experiencing. Young people were often very committed to say, I want to avoid pregnancy, and that was important in how they chose what contraceptive method they ultimately decided to use. Autonomy and choice was also very important when they were choosing a method, as was privacy, not having lots of other people knowing what they were doing and being able to choose that on their own. And lastly, for male youth only, females did not mention this, the impact of the contraceptive method on their sexual encounters was also mentioned as important. Very importantly for young adults, and maybe more so than other population groups that we took a look at in this series of reviews, social context was mentioned as very important in 26 of the articles that were included. And these levels of influence ranged widely from the interpersonal level to community and more societal levels. And at the interpersonal level, we could see influences based on peers. What are other peers using? What are other peers recommending? I liked this, you should use it too, and capturing values and preferences from that. Parents also had a lot of influence for adolescents and young adults. And if they had a partner, the partner's their relationship status with their partner or their partner's attitudes also had an influence on values and preferences around contraceptive methods. Also, this larger picture here on the side just is trying to capture this idea of the young person's social goals. What was their identity? Where did they dream of going? What achievements were they trying to capture? What were their aspirations? And all of these desires of where am I headed in the future? What are my roles? What are my goals in life? That really shaped what kinds of values and preferences they had around the contraceptive methods. Kind of like Anita was talking about how quickly you wanted to return to fertility mattered if you planned to have children, and sometimes people said, I don't plan to have kids, and so I'm going to take these longer term methods. And so that really shaped what people decided to use. Peer pressure was also really important, especially peer pressure to avoid pregnancy, often mentioned among school-aged youth. And social norms were also very important, as was confidentiality. For every contraceptive method, we can talk about these in quite a lot of detail for one method at a time. But for youth, they too weighed the pros and cons of each of the contraceptive methods that were available in their method mix. And so I won't talk through each of these at this time, but there are a lot of different thoughts that the youth had about which method should I use, what are their benefits, what are their cons. Myths and misconceptions were also pretty important to youth, and these were often just things that people did not know or did not understand about the different contraceptive methods. And some of the myths that came up through our review, were the thought that if you have condoms available in schools, that's going to lead to behavioral disinhibition. People are going to have sex all the time. They're not going to pay attention to school, have decreased academic performance. Some people believed that condoms caused STIs. So there's a lot of room for potential education and engagement in that way. Some people also believe that using the oral contraceptive pill caused abortions, and we're not sure how certain methods were effective, right? So if the vaginal ring was not commonly used, they weren't sure, is this actually effective? Is it going to do what you say it's going to do? How does it work? And it leads to issues with mistrust. Maybe I don't want to use it, and a lot of uncertainty about how to make their choice. So just to wrap up, these 55 articles looking at adolescents and young adults covered 18 content areas. Many of them focused on concerns over hormones, the safety of using these different methods, and side effects. These concerns are not unique to this age group, and so along the same veins, we want to think about what kinds of methods do we want to promote, and as we promote them, how can we help people to think about initiating them, maintaining their use of them, or switching between methods depending on what is best for them. Distinct to this group is this idea about social context, and so we just wanted to emphasize the unique time of transition for adolescents and young adults. And lastly, this idea of privacy and confidentiality was very common throughout the articles that were included in this review. We noted that many of these privacy confidentiality issues were commented in terms of privacy from their parents, and sometimes also from their peers, but people very rarely mentioned anything about keeping confidential from their partners. So that was kind of interesting. And we hope that the values and preferences presented in this review help us to shape better how to approach contraceptive care, how to structure services through shared decision-making, especially keeping in mind the very special legal literacy and power dynamics for this age group, and how to work through these social norms so that we can give the best access to services. So thank you for your time, and we're going to skip this poll as well and move over to Caitlin.
Thank you so much, Teresa, and a great presentation. So our last presenter, Caitlin Kennedy, is an associate professor at Johns Hopkins Bloomberg School of Public Health, where she also serves as the director of social and behavioral interventions program. Trained as a social and behavioral scientist in both qualitative and quantitative methodologies, she applies these methods to the development and evaluation of innovative HIV prevention interventions and strategies to improve health and well-being of people living in resource-limited settings. Welcome, Caitlin.
Thank you very much. So my role here is to present values and preferences from a range of additional populations that came up in our reviews. These populations are not easily categorizable or collapsible into one group, of course. However, we're presenting them in this session together because there are some similarities in terms of social vulnerabilities and barriers to receiving high-quality contraceptive care. And of course, these groups are diverse in these risk factors, contraceptive needs, et cetera, but also often have poor health outcomes. And then I'm also going to talk about values and preferences of health workers, which we all know are also important in shaping contraceptive care. And this panel is really talking about this series of systematic reviews that were done, so I just want to highlight that this is pulling from a range of different papers led by other people and that I contributed to, but thank you for those people who did work on all of them. So we'll start with people living with HIV. This was the category of sort of specific populations, that had the most number of studies, perhaps unsurprisingly. There's been a lot of research on HIV in this space, and primarily this work came from sub-Saharan Africa, again, not surprising given the HIV prevalence in those settings. Values and preferences in this group were similar in many ways to those from other groups that we've discussed today. They were shaped by contraceptive method availability, access, convenience, perceived effectiveness, safety, tolerability. Dual protection came up with this group in particular, fertility desires and partnership dynamics, and also provider recommendations. Male condoms were discussed frequently, particularly because of the dual protection against HIV and unwanted pregnancy. So they were frequently a preferred contraceptive method for these reasons. Also because providers often emphasized the importance of dual protection, so people living with HIV were aware of that heightened interest. There were fears of infertility and side effects, and this decreased interest in hormonal contraceptive methods. And again, as we've seen in some of the other reviews, but this came up particularly in some of the studies of people living with HIV. Specific to this population were also discussions of financial burdens incurred by both needing to deal with HIV management, attending clinic, coming for sessions, and reproductive health care, and a desire to reduce these dual burdens. So for example, the dual burden of taking pills for antiretroviral therapy and for contraception. And then healthcare providers were discussed commonly in these studies as contributing to their contraceptive values and preferences and informing people's perceptions of what I, as a person living with HIV, can take, should take, what's safe, what's tolerable, what's effective. And this discussion of dual protection, again, came up regularly in terms of how providers were framing contraceptive choices to people living with HIV. Moving quickly. The next group that we looked at was sex workers. We had 6 studies that looked at sex workers specifically, and interestingly, all of these focused on the female condom and sex workers' perceptions of the female condom. The studies were diverse in their locations, and the sex workers in these studies talked about the benefits of the female condom, including the ability to discreetly insert it ahead of time, to have vaginal intercourse during menstruation, and increased negotiating power for safer sex. But most studies also reported difficulties related to the physical attributes of the female condom's rings, including the size of the rings, the ease of use, ease of insertion, misdirection and slippage issues with the female condom. And all of these studies discussed the impact on sex workers' work and the sexual experience that they had with clients, so issues of noise and discomfort and concerns about that in relation to client experiences, but also some feelings that protection against STIs allowed for more pleasurable sex and less worry during sex work encounters. We only identified one study that focused on trans and gender diverse individuals and their preferences, and this focused on trans masculine individuals. This study was a qualitative study from the United States, which looked at implants, male condoms, oral contraceptive pills, and found a variety of similar themes that we've seen in other studies around effectiveness and safety, hormonal effects allowing for menstrual management, and then some specific experiences like the desire to avoid feminizing hormones and improve gender dysphoria relation to hormonal effects of contraception, and then physical attributes of the contraceptive methods, such as discomfort. And finally, stigma was a major theme here, as we will see with some other populations, and particularly in this case, stigma around discrimination from healthcare providers and gender bias in contraceptive care. Moving to the next group, for people who inject drugs, we found 2 studies from Australia and Brazil that looked at people who inject drugs. And again, participants in both studies valued effectiveness and safety of methods in particular, and were worried about side effects and interested in dual protection. Interestingly, again, specific to this population, although concerned about side effects, people who inject drugs, particularly in the study from Australia, really valued fertility regulation and viewed contraception as a tool to delay childbearing until they were at a more stable point in their life when they could then, but when they did want to potentially have children in the future. Finally, among the specific populations, we found 4 studies from humanitarian contexts. So these included a range of countries, as you'll see here, Ethiopia, Uganda, the UK, and Australia, including both asylum seekers, refugees, and internally displaced individuals. All of these studies described themes that focused on values and preferences related to birth spacing and family outcomes. So the idea of having more children or having fewer children because of the specific social contexts of these individuals was very important. 2 of these studies talked about the importance of regular menses among these communities, and then 3 studies looked at the effectiveness and safety of methods as really and particularly important. And we did see some sort of the social context coming out in these populations as well, in terms of the associations with the culture of origin and the traditional beliefs around contraceptive in those cultures of origin, and then also the experience with things like use of interpreters. So for example, stigma came up with this population, and stigma may have been around the use of an interpreter who the individual seeking contraceptive services may have assumed would have values and preferences related to contraception that were in line with the traditional beliefs of the culture that they came from. And so that was sort of an additional issue around stigma and sensitivity. So briefly, across these groups, we found similar themes in terms of autonomy, effectiveness, safety, and impacts on sexual experience, hormonal effects. Some of the specifics that came out from these groups were stigma, and stigma was around varying topics. So stigma around living with HIV, stigma around infertility or the number of children that you want to have or are able to have or might be perceived to have, stigma around sex work, so really a range of, and stigma around being trans or gender diverse. So again, stigma from different sources and around different experiences. And then birth spacing, family outcomes, specific sexual experiences across these different groups did differ. And then finally, we also looked at values and preferences around health workers. We found quite a lot of studies relatively that talked about how health workers felt about specific contraceptive methods. And we classified these into 3 different categories that health workers felt differently about different contraceptive methods based on the contraceptive method characteristics, so the bleeding pattern, convenience, etc. The contraceptive user themselves, so several studies talked about health workers seeing different methods as appropriate for different populations based on their age. So certainly with young people, for example, some studies showed that health workers had particular opinions about which methods were good for young people versus older people, or people with different marital status or parity, literacy level, and medical diagnoses. And then also we found that these preferences were shaped by characteristics of the health worker themselves. So health workers from different subspecialties with different trainings. There was discussion about trainings from 20, 30 years ago versus health workers who were more recently trained. The depth of experience with contraception in particular. So some studies were looking at a range of health workers, some of whom were specialists in contraceptive service provision and others who were not. And then the environment in which they were providing services, what kinds of methods were available, what kinds of pressures were on the health worker to conform with either sort of social norms and rules or with expectations from the health system around providing services. And we also found in these studies a number of studies that documented that contraceptive counseling and provision was infected not only by their own values and preferences as a health worker, but also by misconceptions and biases. So for example, misconceptions that LARCs are not appropriate for young people, et cetera. So in conclusion, there really has been, on the one hand, there's a lot of studies out there. On the other hand, there's really limited information when you drill down to specific groups and populations. And some of this is really limited in terms of the types of questions that are being asked. So for example, that all the studies with sex workers were really looking at the female condom. The themes across these groups were diverse and somewhat specific to the specific groups, but not always. Sometimes they were more generally similar to themes from other broader populations. Health worker values and preferences are important. They influence health worker provision of services and are shaped by a number of factors around their backgrounds and environment. And there's a need to address issues in terms of gaps in health worker knowledge and training, particularly to reduce overly restrictive perspectives and harmful biases that health workers hold regarding certain contraceptive methods and populations. So we'll wrap up with a few key takeaways, and then we'd like to open it up for discussion. So this series of systematic reviews, as we've said, was used to inform the WHO guidelines around the MEC and the SPR. We were encouraged in many ways to find the number of studies that we did find from a really diverse set of global settings, a diverse set of populations in many ways, and covering the range of method mix that we were interested in. On the other hand, there were gaps in this literature, despite the large amount of literature. In particular, for the MEC and the SPR, one of the questions that Mary Lynn highlighted at the beginning was the interest in values and preferences regarding the specific health issues that are covered in those topics. So cervical cancer, breast cancer, venous thromboembolism, obesity, et cetera. And we found a lot of gaps in that with not really much research. So if anyone's looking for research topics for the future, that could be very much used to directly inform WHO guidelines around those areas. And as we've mentioned, this series of systematic reviews, if you'd like a lot more detail, you can go to the July 2022 special issue of Contraception, which has each of these reviews in detail. This is the QR code. You can follow the WHO, and in particular, this work here. And if you are interested in sort of access to more details in the data that we extracted, we have large spreadsheets that cover a ton of information. So if you're looking for a specific country, what were the studies from Kenya? What were the studies that looked at this particular method? What are the studies that looked at this particular population, et cetera? We can sort and organize that data. And Teresa's email is here, and we're happy to share that with you if you reach out to us. They're also in appendices to the contraception special issue. And we want to end just by acknowledging that this was not done just by us, but by a large group of individuals. We thank the contraception editorial and Elsevier staff who really helped move this forward, all of the co-authors on the reviews in particular who did a lot of work. And we also had a large team of graduate research assistants at the Johns Hopkins School of Public Health who helped us in sorting through those 8,000 citations and things like that. So thank you to all of them.
Yeah, thank you so much, Caitlin, and the panelists for very nice presentations and for the great work done on these reviews, and also for keeping to time. I think they've given us 10 minutes where we can do Q&A. We'll pass the mics. Probably we'll take 2-3 questions and then ask them to respond so that we can end on time. So, yes, right at the back.
Hi, my name is Danny Resar. I'm from CHI, and I'm actually coming from the HIV prevention space. So thank you for all the really wonderful presentations. I think learnings from the family planning space, where you've had a lot of years of experience with the multi-product menu, are going to be really important for us in HIV prevention as we're starting to look at new products entering the market. So one of my questions that I had for kind of the whole panel group is that there is an emerging body of literature in HIV prevention, and I've seen some of the really similar themes to those that you highlighted here. So preferences for discrete products, also effectiveness coming out as a really important attribute across different populations, different products. So on effectiveness, I was just curious if any of the panelists had any kind of reflections on effectiveness or any of the other attributes that kind of the definitions in user experiences may vary over time. So I think in the HIV prevention space, we see, again, effectiveness is really important to end users. But at the same time, I've also seen qualitative research that once people start using a product, you kind of just think about it as effective or not. So something like variable effectiveness isn't actually on the mind of a user once they're using a product. So just curious if anything came out in this review about effectiveness and different levels of effectiveness and how users experience that. Thank you.
Thank you. We'll take another question. Yes.
Hi, good morning. Julia Bunting, President of the Population Council based in New York. Thank you. Fascinating discussions, really, really impressive work. A couple of questions. Anita, you talked a bit about questions around sort of insertion and when methods are inserted, and I wondered if you had anything around removal. We know that's been a big issue for long-acting reversible contraception, in particular when we think about contrasting provider methods versus self-care. And then, of course, just keen to hear more about the gaps from all of you. Where were the really big gaps that we've got missing, and what are the future research questions that we need to be asking and answering to move this agenda forward? So thank you so much.
Thank you. Any one more question? Yes, Eba.
Hi, good morning. I'm Ibrahim Balami from Northeast Nigeria, and I'm working within a humanitarian setting, specifically with adolescent and young people. And thank you for all the wonderful presentation. I'm glad you had something about the humanitarian context as well. My question is, in all of the reviews, has there been any literature which you came across that helps to demystify adolescent uptake to long-acting contraceptive method? Because we've seen from even the presentation that service providers have a certain level of biasness when it comes to age and marital status for adolescent accessing family planning. We're moving toward family planning 2030, and if this barrier is still there, are there any recommendations you will have for us working within such humanitarian settings that will help us in a long way? Thank you.
Yeah, thank you so much for those questions. I think I'll ask the panelists to respond. Probably we start from Caitlin or Anita, whichever. Yeah, go ahead.
Thanks, James. Okay, I can start with the first two questions maybe and then pass it on. So the question from, sorry, I forgot your name, but from Chai. It's really funny because now that is exactly what I work on. So trying to bring family planning and contraceptive principles to this like new generation of HIV prevention technologies that are coming to market. And, you know, there is obviously oral PrEP already, and now we're trying to introduce the PrEP ring or the Dipivirine ring, and, you know, there's concerns about effectiveness for this product. And then there's the Cab-LA injectable, which has high effectiveness, but, you know, we're missing effectiveness data for certain populations like pregnant and breastfeeding. So there is completely understand, you know, this whole question about effectiveness is concerning for a lot of people, especially when we're talking about trying to end an epidemic that has been raging for a long time. So in terms of contraceptive lessons that we're trying to now apply into this space, you know, informed choice, having a broad method mix, these are all applicable. I think we know that women and adolescent girls and young women, they're a very, especially AGYW, they're a very vulnerable population, and they need to have accessible options. They need to have, choice with demedicalized options. Not everyone is, comfortable going into a clinic every 2 months and dealing with a different set of providers or staff. So when it comes down to it, I think, making sure that all the information is out there when it comes, including effectiveness, but, making sure there's other, making sure each product in the HIV prevention space, the complete profile of that product is translated to the potential user, and then they can make a choice, with their provider, with whoever else they want to consult. So I think a lot of the lessons that we see from these systematic reviews and from the contraceptive space are directly applicable, and and then, if we're really going to talk about it, at the end of the day, condoms are the only ones that are really out there preventing pregnancy and HIV and STIs. So, and then, sorry, that was a bad ending to that answer. But I think we all know where I was going. And then for Julia's question about removal, because from the results that I presented, it was mainly about insertion. We not a lot of discussion around removal, but I think one thing we saw is from those 4 subgroups, 3 of them have they're going into facilities and they're getting counseling. And so I think we can assume, because they have these, regular check-ins in like a facility or like in a medical setting or with a healthcare provider, that there is probably data that we're missing on removal that, is very similar to the data we have on insertion. Okay, I'm going to pass it on.
And it may actually be too soon, because they've not really been increasing in the last 10 years, and they're only in the last 5 years, and we just may not have enough data to look at aspects around removal yet.
Yeah, definitely.
No, I actually was just going to say that. I think, we have to think about the time frame of these reviews, and as Anita highlighted, sort of there was a attention to LARCs for a period of time, right? And that was informing the decisions that were being made at that time, and then that gets reflected in the scope of these reviews. So that leads me a little bit into the answer about what are the gaps in research, because I think it's interesting and obviously important when there are sort of programmatic considerations and new methods or new approaches to be studying those. And I think things change over time, right? So we can't assume that 20 years ago the values and preferences and perceptions are going to be the same moving forward, even among methods that have been around for a long time. And so I think continuing to look at that, even though it's not, always you may find something that's not that surprising and not that different, but it's still helpful to say, okay, this is still kind of consistent. We're not missing something. And we had a number of conversations with WHO and the group and the guideline development group that was working on the method, sort of saying well, don't we know all this already? And we were saying, well, that's actually good, because it means that we're not finding surprising new things out there in this literature that that providers in general don't sort of have a gut knowledge of as they're doing their work. The other gaps I would say is, so speaking to gaps in research, I think the question is really about who's the end user of that research and what is it going to inform. And we were originally doing these reviews for the sake of the WHO guidelines to bring in sort of that user perspective. They also had end users and, in person at the guideline development meetings, but this is a broader assessment of sort of the range of end users across countries and across populations and users. So to inform that, and from that perspective, I do think that some of these very specific health issues and population groups that are covered in these guidelines that have specific contraindications to use have not been well studied in terms of how do people then feel about that, or how do they think about their contraceptive decisions around that. And then from the perspective of sort of specific populations that might have specific service needs, so like sex workers or transmasculine individuals, or really trans and gender diverse individuals who might access service in different places, who might have different barriers to service use, we really found a lot of gaps sort of for specific populations. And I don't think it's important to look at
people who have blue shoes versus red shoes, right? But if there is a sense that services might be tailored, so people living with HIV, for example, are often getting services in HIV clinics and in their continuity of care. And so for that perspective, that shapes their experience.
Oh, we are actually at timeout, but thank you all for being here.
Yeah. Yeah, and let's appreciate the panelists for vast presentation.